Hi guys, it's Dr. Holliday here with Any Direct Docs. So excited to once again have Dr. April Krowel from the Brain Center with us. She does therapy for patients who have dementia or are caregivers of loved ones with dementia in McCoordsville, Indiana. So excited. We were just talking about how it's very common and normal as you age to have memory loss. And so what people always want to know is what is normal, what is not normal, and when should I get tested or be worried that my memory loss could be dementia?
Yeah. So when we age normally, we tend to have like speed problems, not necessarily motor functioning, but we slow down because we're aging. We slow down physically, but also cognitively. So sometimes that processing speed, might take folks a little bit longer to think of what they want to say. Um, Mental flexibility, so we become a little bit less uh, able to go back and forth between tasks and multitasking, those sorts of things. And we absolutely can have less efficient memory. We really have to sort of fish through our memories to find out, oh, yeah, that's what happened. But memory declines and significant memory decline is not necessarily normal. So um, we we can learn new things as adults. We can create new memories as adults, and we can actually improve our vocabulary as we age, which is actually something really fascinating to me. Any novel skill as you age, you can actually learn. So that's something that's pretty awesome. So even though grandma and grandpa say they can't learn about the computers, they really actually probably could. Um, so if you really sat down and helped them learn, barring any other cognitive decline. So when I learned that, I was like, oh, okay. But yeah, so some of the signs that you might actually worry about are significant word finding problems where you really can't get those words out. So it's on the tip of your tongue. It does start happening usually in your 30s, and it gets worse every decade. So that is normal, where you kind of think, okay, what is this word I'm trying to say? I do that all the time, actually. But if you can't have a conversation with people, then that might be something to really be worried about. The other thing too that I really look for people, memory wise, it feels like it's memory, but it's when they get lost in familiar places. So if you always go to the same salon, for instance, to get your hair done, or the same grocery store to shop, and all of a sudden you can't get there, that's also a problem. So I'm not talking about going to an unfamiliar place where, you know what, I'm going to go try this grocery store on the other side of town, and then you get lost. That's different. Um, so it's very familiar places. If you can't remember people's faces, also, places and faces. If you can't remember their faces and their names, then that's also going to be a problem. And that could be something else besides dementia, because I assess for a lot of different things. But normally that memory component is there for those sorts of things as well. So you might hear dementia be called, like, it's a neurocognitive disorder now. It used to be called dementia. We still call it dementia in conversation.
For
So those are sort of,
terms, because that's
what's
what people,
that? Yeah,
for
yeah,
layman's terms, because that's what people know.
absolutely, yes. So the I'm trying to find. I actually have some information here for, like, to watch for, so I don't forget. So again, getting lost in familiar places, the repetitive questioning, and I don't mean by I'd ask you a question today, and then next week I ask you the same question. I'm talking about the same conversation, and over again. Sometimes people who have dementia of any kind might ask, hey, are we going to go to lunch? And then within a few seconds or a minute into the same conversation, hey, are we going to go to lunch? And then you're like, yes, I just told you we're going to go to Sullivan's. Or wherever. And then they ask again, and then they ask again, because they're not, that short-term memory is just gone. Those sorts of things are, more significant, and they definitely impede our functioning. So, Odd or inappropriate behaviors is actually part of a dementia diagnosis called frontotemporal dementia. So even though we have the dementia umbrella, we have Alzheimer's, we have vascular dementia, and several other types. FTD is actually has a behavioral component. So these people who are experiencing FTD have ridiculous personality changes, like they go 180. I actually had somebody in my office the other day who had it, and his wife described him as a completely different person. And typically, unfortunately, there tends to be sexually inappropriate behaviors. So, excuse me, and they don't understand why it's wrong, because the frontal lobe of the brain is where we make our good decisions. It's where we have impulse control, and those things are just shrinking. So sometimes I give the example a lot of times to my students of the man he was a veteran. He went out and he started mowing his lawn naked, and and of course he would have never done that before. It's socially inappropriate, it's sexually inappropriate, and he had no idea why it was wrong. And so those absolutely will happen as well. Any kind of changes in eating habits, diet, those, and any other like language, including comprehension. So if you're not really understanding what people are telling you, then that also might be a good sign, or a bad sign, I guess, that there's potential cognitive decline of some sort.
Mm-hmm. What is the testing that you do to confirm a diagnosis of dementia?
It depends on how severe. I do what I call a flexible battery of tests. So I tend to have very core things to look for, and then once I'm done with interview with the patient and the loved one that comes with them, then I will add everything else or take things out based on what that looks like. So if somebody's pretty impaired, I don't want them to be mad at me all day and frustrated, because they're not going to be able to do a lot of the things I ask them to do. So I will make my battery as short as I can, but also being able to get that information that's required. I have a battery that's as short as 4 tests that I can give to look for dementia, assess it, and also assess for capacity to make decisions. So at the bare minimum, I can give someone 4 tests and then get them out of here, which is nice. And then at the other end of the spectrum, if you're more mild or not sure, then you could be here for 4 to 6 hours. And then I really flush through everything, as long as you're going to let me do it. But again, I try not to give tests that I don't need to give. That's something that's super important to me. And I tell people all the time, I don't want to torture you in here. I want to just get the answers. I want you to not be mad at me the whole time, because it's not going to help the performance. And we just need to know what's going on. So, and then we can help you in whatever way that looks for you.
Okay. And your tests are mostly just questioning to just determine what is their functional status, and maybe doing some like word puzzles or something like that?
Yeah, so it's a mix. It's a good mixture of a lot of different things. So I test for, I look at premorbid functioning, which just means where you were functioning before you started having problems, like our best estimate of that. Because then I look at that score and I compare everything else now to that score. So that's really important. I look at orientation. Do you know where you are? Do you know what's happening in the world, like around you? I look at IQ testing sometimes, depending, academics, depending on how old you are. Then I will also look at language, memory, of course, executive functioning, visual spatial abilities, motor functioning if you don't have arthritis or tremor, because then I'm just measuring that. I look at personality and stress management, because that absolutely plays a role. A lot of people don't know that if your depression is so severe, it will look like dementia. So someone relatively healthy coming into my office, relatively young, thinks they have dementia. And my young people, I'm talking about 50s, 60s, they come in and then they might just be severely depressed. And it's not to minimize that, but that can be treated, and dementia can't. So I do have sometimes people come in my office and they're upset that they don't have dementia. And I'm telling them they have depression, but it's really that it's again that mental health stigma of they want a medical reason, they don't want a mental health reason. And
Mm,
so digging into that and talking through like, hey, this is the depression, this is the D that you want, right? You don't want the dementia diagnosis. You want, if you're going to have either or, we want to pick the depression because we can fix that. We can
yeah.
help you with that.
Yeah.
Yeah,
Okay. Great. Well, this was very, very helpful. Thank you so much for your insight.
absolutely.
Yep.
Thank you.
All right. Thank you. Bye.